Weaning. We are in conversation with Dr. Sameer Zog, consultant intensivist, Dinanath Mangeshkar Hospital and Research Center. In part 1, we discuss about definition of weaning, its causes, and how to evaluate a patient. We further continue our discussion with him to understand about bridging interventions and new insights. How much does the primary disease play a role in respiratory failure on weaning? I mean, what's the impact of primary disease on it?
Probably the most important factor which will play in the weaning is primary disease, right? So if I'm ventilating a patient for pneumonia and ARDS, so unless my lung architecture is improved, gas exchange is improved, lung compliance is improved, my patient is unlikely to get weaned off or unlikely to get off mechanical ventilation. So primary disease will always play a role in weaning. And then the duration of mechanical ventilation or the preventable things which you have performed during mechanical ventilation, which I will list. But the primary disease definitely takes a role. And according to your primary disease, you may have to take certain steps, which we will discuss in next part of our talk. But the preventable things during mechanical ventilation are first of minimal use of sedation and neuromuscular blocker, which are preventable. The primary disease is not in our hands. Patient comes with primary disease, which you and me cannot control on that. But what we can do during mechanical ventilation when patient stays in the ICU along with us, what we can do to prevent difficult weaning, or I would say not prevent, but at least facilitate weaning when we think of weaning, that these interventions are minimal use of sedation and neuromuscular paralysis. Use paralysis only when it is required, for example, during mechanical ventilation or during significant asynchronies or dysynchronies during mechanical ventilation leading to life-threatening gas exchange or hypoxia issues. So avoid neuromuscular paralysis as a routine drugs in your ICU. Take care of nutrition, especially for protein intake during mechanical ventilation, because many of us believe that nutrition means give some RT feeds of 100 or 150 cc every 2 hours and that will take care of patient caloric intake. Is not correct. So we have to really calculate sometimes by using urea nitrogen studies or blood urea nitrogen and urine urea nitrogen calculation to actually look for catabolism for this patient. So adequate nutrition is the key to prevent neuromuscular weakness in many of such patients. Third is the glycemic control. But you have to control your blood sugar during the course of mechanical ventilation. Not very tight sugar control, but at the range of somewhere around 140 to 150. Or the range of 140 to 180 is considerable adequate, which your insulin, you should control your blood sugar. Avoid fluid overload, because many a time what happens during resuscitation phase, all of us give liberal fluids to combat shock or combat worsening pathology. So when we think of weaning on say day 5, day 6, day 8, many of our patients are in actually fluid overload if we calculate cumulative balance. So always avoid fluid overload. Use diuresis if required to make patient U-balance considering your insensible losses. So avoid fluid overload would be fourth trick, which is in our hands. Fifth would be correct endotracheal tube size. If patient has undergone emergency intubation, some in outside hospital or in your emergency room, then before weaning, see the appropriateness of the size of endotracheal tube. Many of the time it happens that patient has got COPD exacerbation, a male patient with actual weight of say 90 kg and BMI of 35, he has having endotracheal tube of 7.5, which is obviously inadequate for him. You have to upgrade the tube size to at least 8.5, maybe 9 in some cases, and then think of weaning or start weaning process in this. So correct size of endotracheal tube or correct size of tracheostomy tube may be required before you start weaning. And sixth thing is good airway toilet, which is important, that if the airways are clogged with secretions or with mucus plugs, then obviously they will going to hamper your weaning process. So these 6 things which we can definitely do in our patients during mechanical ventilation or before weaning to make our weaning easy and to avoid some instances of difficult weaning.
Yeah, thank you, sir. If you could quickly also tell us about the bridging interventions in weaning during extubation process, what we try, different measures, but just put a light on that as well.
Actually, if you say weaning is by a strict standard scientific description, liberation from any assisted respiratory device would be called as weaning or liberation. But get rid of invasive mechanical ventilation can be called as a weaning in many cases, because sometimes we wean them to other modality. For example, patient of COPD, we extubate them and put them on NIV, which we may use for a prolonged period of time in our wards or even sometime at home also. So bridging techniques are something which are not invasive, which are obviously non-invasive techniques many times, which are two are important. High flow nasal oxygen is now very common in Indian ICUs. We have used them in last 2 years significantly during our COVID pandemic. So HFNO is not only the modality which can be used before invasive mechanical ventilation or avoid invasive mechanical ventilation in hypoxic respiratory failure, but if the patient fulfills weaning criteria but still requires mechanical ventilation because he fails weaning trial, then these patients, if they are conscious, alert, well triggering breaths, HFNO can be used electively after extubation as well. So in this case, HFNO will be a bridging intervention during your weaning. The classic example of bridging intervention is NIV, which I have already elucidated. We are doing this for almost last 25 years. COPD patients who are difficult to weaning, we often extubate them and then put them on NIV with a CPAP of 6 to 7 centimeter, which will commensurate for their intrinsic PEEP, and then pressure support of say 5 to 8 centimeters depending upon the respiratory effort. We keep them on NIV either continuously or intermittent NIV. And if the disease or pathology is still not corrected well, we may continue this NIV in the room, or we may discharge them patients at home also with home NIV. So NIV and HFNO are bridging interventions, but there are two interventions which are little invasive but worth trying in patients of difficult ventilation. For example, you are ventilating a patient with traumatic brain injury or large IC bleed or subarachnoid hemorrhage. Then doing tracheostomy might be helpful to get rid of mechanical ventilation. Of course, the scientific data will show you that doing tracheostomy early or late doesn't make any difference. But especially in Indian ICUs, where our nursing ratio is difficult, where infection rates are high, doing tracheostomy is often a prudent thing, and we can't get rid of mechanical ventilation quickly in our Indian ICUs. So mobilization will be easy, sedation use will be less and less, and the risk of infection with the ventilator is little less if we do tracheostomy. Of course, there is no scientific data, but at least in Indian ICUs, tracheostomy would be definitely helpful in our case. And sometimes endoscopic PEG implantation or jejunal feeding or gastric feeding, which will definitely helpful, especially in patients with chronic subacute brain injuries or which are turning to chronic brain injury. For example, severe traumatic brain injury, grade 4 SAH, large IC bleeds, large dense stroke, MCA strokes. In these patients, the swallow is not improved even at the end of 2 weeks or 3 weeks. Then it's worthwhile to do PEG or jejunal feeding, which will prevent quantitative aspiration and which might help you in liberation from mechanical ventilation. So use of HFNO, NIV, tracheostomy may be little early as compared to Western ICUs, and use of feeding techniques, either jejunostomy or percutaneous endoscopic gastroscopic feeding, might be used to facilitate weaning.
Sir, what are the new insights available? Any new indicators or different ways of assessing the patient on it? Could you please tell us a little about that?
Two new insights, out of which the one which I already talked about is assessment of diaphragm with your ultrasound, which is now gaining quite popularity. And since the ultrasound is now become our routine tool, it is now a new generation stethoscope that our critical care fellows and DNB or DM students often use ultrasound machine more commonly than stethoscope for evaluation of heart and evaluation of lung. In the lung evaluation, they must learn now to assess the diaphragm, means the thickness of diaphragm, the contractility of the diaphragm, the serial evaluation of the diaphragmatic thickness in posterior part and anterior part will definitely give you a clue for difficulty in weaning. So diaphragmatic evaluation by ultrasound should be added to this patient. And second is not a new insight, but it's actually an old technique described almost 40 years back. It's called as P0.1 technique or P0.1 muscle pressure understanding. All modern ventilators has got this facility of P0.1. What is P0.1? P0.1 is nothing but you press an inspiratory, give pause to inspirate for a spontaneous breathing patient and see how much negative pressure development is occurring in a given patient. In a patient who has got significant respiratory effort to maintain his gas exchange, the P0.1 goes beyond -3. So it may go up to -5, -6, -7. In a normal individual where there is no significant respiratory drive or no significant respiratory effort, the P0.1 is often 1 centimeter, 1.5 centimeter. So this is a good tool which is not commonly practiced in our ICUs, but it is worthwhile to practice that. See the patient drive or respiratory muscle drive or respiratory muscle activity during inspiratory pause. It will give you a good clue that whether this patient is heading for a prolonged weaning or still he can be weaned reasonably. Then use of echocardiography for cardiac evaluation. So very often our physician colleagues or cardiology colleagues believe that once echocardiography has been done at the initiation of mechanical ventilation and there is no structural anomaly, LV ejection fraction is normal, no diastolic dysfunction, means this will remain for his life. This is not true. Echocardiographic evaluation has to be dynamic and has to be done repeatedly, especially patient with difficult weaning. So in patient with difficult weaning, I would suggest everyday echocardiography evaluation should be done because we are struggling with a respiratory pathology which is not resolving. And the diagnosis of sepsis-induced cardiac dysfunction or LV dysfunction because of ischemia or because of stress can occur any day. It is very difficult to diagnose clinically. So echocardiographic evaluation or repeated echocardiographic evaluation is a really new sight. And we have learned in COVID in a very hard way that we have always seen unexpected pulmonary embolism or unexpected pulmonary de novo thrombosis, which was probably not very commonly diagnosed before COVID, but during COVID we have diagnosed this entity quite often. So I think it should be considered if we are really dealing with difficult ventilation or prolonged ventilation, at least one evaluation with CT pulmonary angio should be done for this patient to avoid the surprises. This patient might be developing de novo pulmonary thrombosis or might have developed embolism, which is actually creating problem during your mechanical weaning process. So judicious use of CT pulmonary angio is really new insight during our difficult weaning protocol.
Thank you, Dr. Zog. Thanks for doing this. It was really great talking to you. That's all for now. See you again. Thank you.
Thank you, brother. Thank you.